Should I start? Okay, so hello everyone. I'm Kamil. I work for Arden and GEM, and this presentation is going to be on the stratification tool that we have developed as an organization, whose purpose is basically to predict the probability of death within 12 months of starting a pathway for basically people currently on pathway waiting in Cornwall and Isles of Scilly region. So just a background, I think that you probably heard today a few times already. So waiting lists, waiting lists have been obviously growing over the last few years for a number of reasons, obviously pandemic being one of them. And obviously with that, you have a lot more people waiting for treatments. We know from evidence that delay to some treatments, like for example, treatments related to cardiac issues or oncology treatments, those can lead to exacerbation in risk of death. And so delays in treatment are a problem. More people on waiting lists, potential for deaths. And so that's the reason why we've developed the tool in order to identify those who are high at risk of mortality on a waiting list in order to be able to essentially prioritize these patients in some way. And so what we did to develop the predictive model, it's this very, very sort of typical machine learning sort of development cycle. So we use essentially two different data sources. We use the open pathways data source, which is basically everybody who's currently on a pathway and has been on a pathway in Cornwall. And then also we've looked at basically the death records, essentially. So it's a retrospective model fitted on retrospective data. And so what we essentially needed was we needed a 24-month window whereby, you know, we used 12 months to look at who started a pathway within that 12-month period, and then we looked at whether they have died within the next 12-month period from the beginning of their pathway. So we needed 24 months essentially to cover, to get our data. Then we were sort of lucky enough that the features within those two data sets upon combination was sort of sufficient for us to develop some good models. And so the feature engineering bit was sort of limited. There was not much we had to do apart from cleaning the data a little bit. And then we just fed the data, obviously, typically through your sort of like, training. So you take some data, you train. We used cross-validation basically to validate different kinds of models. And ultimately, we settled on a model whereby we use oversampling in order to bring the data into balance. Because as you might imagine, most people, when they enter a pathway, they do not die within 12 months. And so you need to, in order to kind of improve the ability of the models, we oversampled a little bit to basically make the data set a little bit more balanced. We used logistic regression for feature selection. So we tried different methods for feature selection. In a cross-validation sort of cycle, you would try different things iteratively and basically select sort of combination of hyperparameters that basically give you the best prediction using an evaluation metric. And so the evaluation metric that we used is called F-beta score. And that metric is specifically used to basically maximize both precision and recall in the performance of the model, whilst also making sure that precision and recall are balanced. So it's a harmonic average of the two. And so ultimately, our resultant model was basically a logistic regression feature selector, a model, and then a logistic regression at the end as well that actually does the prediction. So it's sort of like two logistic regression models on both ends of the pipeline. And that was based on the evaluation metric, but also based on the fact that because the performance differences between logistic regression and more complicated model weren't very big, we decided to go with the simpler model because of the interpretability of it, basically. And so we'll get onto the interpretability. So in order to sort of understand the outputs of a logistic regression, I think we need to understand odds ratios. So I'm just going to very quickly talk about those. So you have a sort of a longer explanation of what odds ratios are, but I'm just going to very quickly talk about it in my own way. So an odds ratio is simply a probability. So if you have an event occurring, so in this case, whether somebody's going to die in the next 12 months, you take that probability and you divide it by the probability of somebody not dying. So it's basically P divided by 1 minus P. So it's the probability of an event occurring divided by the probability of the event not occurring. And so basically, if you can imagine, if you have an odds ratio of 5, that's a ratio of 5 to 1, telling us that the probability of the event occurring is 5 times the probability of it not occurring. And so that's basically, sort of that underlies essentially all the calculations that happen inherently within a logistic regression model. So for example, for one of the features that we have used in our model, clinical oncology service, so basically it was a flag, a binary feature that told us whether somebody has essentially has attended an oncology service. That has been shown to sort of contribute towards basically increase the odds ratio of somebody dying in the next 12 months by almost 4.5. So it's 450% increase, essentially. If you have an odds ratio less than that, it means that that particular feature, for example, reduces the probability of somebody dying in the next 12 months. Okay, so a logistic regression. I will try not to go into too much detail, as I sort of assume that people have an understanding of what it does, but I'll try to sort of summarize a little bit and happy to answer more questions on it. So logistic regression is just basically a model that allows you to output a probability of a binary outcome, essentially, and that probability can then be used to basically make decisions. And so in our case, so this is just sort of what happens. So if you think of a linear model, basically in a logistic regression, you fit a linear model like this one, where the weights that you find there are essentially what you learned during the training process. And then you feed basically the output of that linear model into this function called the sigmoid function in order to squash the output between 0 and 1. And that has, because of the inherent properties of this equation there, that basically gives you a probability. So the probability is actually the outcome, the output of this equation. It sort of acts as a probability. And one of the key features of developing a model like this one with logistic regression, because the output of the model is a probability, you can set a threshold that can then be used to basically classify at the end. So for example, you might imagine that if a particular case is predicted to have a 60% chance of death within the next 12 months, 60% would probably indicate that, well, we're more certain that they will die than not based on the model. So you can give it a classification of 1 as in a positive case, this person is likely to die, for instance. So the threshold usually is set up at about 50% to kind of give you that cutoff where you can decide what prediction to make. But yeah, it's not as simple as that, and we'll get into that. So this is the features that we got. So after following the training, after doing some feature selection, this is the top 25 features that we've identified. And so some of them obviously increase. Some of them, if you have a particular individual, if they present with some combination of those features, in some cases, one feature will increase the probability of death in some way, and another feature will sort of mathematically decrease the probability, and then you kind of combine them together in the linear fashion to basically give you the ultimate, the outcome probability. So at the very top, I'm not going to go through all of them. So at the very top, you've got sort of features that you would expect. So if somebody has long-term conditions that are related to heart failure, respiratory conditions, cancer, or if somebody's older, anything that indicates that tends to increase the probability of death in the next 12 months. Features other than features that are related to, for example, living outside of big cities, metropolitan areas, and things like that tend to have, on a population level, tend to reduce the probabilities. But we have to be aware of the fact that these are statistics based on the population level. So, on average, in a population, this is the influence that these features have. But for a given individual, it may not be as simple as that. So just quickly we're going to go through the model performance. And so there's a bunch of ways of obviously evaluating model performance. And I have already mentioned that internally we used this sort of metric that we try to balance between precision and recall. And the reason you want to do that, obviously, so precision is basically, if I imagine my model outputting a particular outcome, let's say, it tells me that this particular patient is going to die in the next 12 months based on that threshold from the previous slide. The precision is basically a measure of how confident I can be that this particular label is correct, basically, that my model has made the right decision, that this true positive is an actual true positive, or that this prediction is a true positive. Recall, on the other hand, is basically, if you imagine all the people that are going to die in the next 12 months, how many out of all those people, the proportion, how many of those will the model sort of be able to identify correctly? So it's like you've got these two sort of different metrics that are inversely related to each other. So a lot of machine learning, in fact, most of machine learning will sort of try to balance the two, as increasing one reduces the other. So you can imagine, if you remember the threshold from that logistic regression model, if I set the probability in my threshold to be, let's say, 90%, I can then only focus on the top 10 risk profiles, basically. And that means that my precision is going to be very high, because then it means that I will only focus on patients who are most likely to die. But then it also means that I'm going to miss out on some patients, because if somebody has a 70% probability outputted by the model, it will not be, it won't be picked up. I won't be focusing on that case, let's say, because my threshold is much higher. So I think there should be another question. Okay, I think there should be a cross. It's okay. So there were two crosses that were basically showing two different points, and they show different thresholds. So it is sort of up to the users of the model to decide where the threshold should be, based on basically sort of a balance between the resources that they have in terms of what they want to invest and in terms of the outcome. So in the case of, obviously, our model, the outcome is predicting somebody's death. So you would ideally want to have a very high recall, because you don't want to miss anybody who is going to die and not intervene appropriately. But at the same time, if you have limited resources, which obviously everybody will, you don't want to also identify too many patients, because you can't help maybe everyone. So you might have to focus on the highest risks in order to basically maximize the outcome based on the resources that you have. And so whatever you set that point based on the threshold will be dependent on how you want to use the model, but it will be balancing between resources and be balancing between not wanting to miss cases. The potential benefits of the tool. So the tool is quite new. So we've developed a dashboard basically that implements the model in the background, and basically for all the patients on the waiting list, you can apply the model to basically make predictions. So that already exists as a tool. It is new, so I'm going to just focus more on the potential of the model, because the actual use cases are still to be sort of determined, the way it's going to be used as such. But some of the key things that you can do, obviously, it is a stratification tool, so it allows you to prioritize certain patients that are high at risk of dying in the next 12 months, for instance. So you can obviously allocate resources to those people, make sure that you intervene in such a way maybe so that you reduce A&E attendances, that you start treatments in a more timely manner, maybe start conversations between themselves and their families to plan, for example, for the eventuality. So that can sort of promote this sort of patient-centered care where families and everybody can get involved. Community services and whatever needs to be involved as well, you can start the process as well for those who are at highest risk. So yeah, tailored treatment plans and enhanced monitoring, again, sort of along the lines of allocating more resources to those who are at risk. But also on a sort of higher, more global level, you can sort of, the users of the model, commissioners and whoever they are, they can use it for benchmarking and performance. They can, over time, obviously, they can make decisions on a population level, sort of looking at, the predicted number of people who are going to die in the next 12 months in total in the whole region that they're interested in, and sort of allocate resources in that way, or create interventions to account for that. Population health management, so use the model and the output of the model as a case selector, so you can look at a whole list of patients, focus on the ones that are particularly at risk, and basically sort of make decisions on that. So for example, you can, for example, check that those patients who are at risk are receiving the right treatment, that they're being seen as appropriate, and research and development as well. And over time, as you sort of collect more data, you develop the models, and at the same time sort of evaluate how effective was the output of the model in sort of guiding policies and their impact, essentially, over time. So just very, very quickly, towards the end. So you can just imagine this would be like a use case, let's say a case study of a patient. So imagine a 75-year-old patient with multiple comorbidities, all of which are features within the model. So for example, COPD, heart failure, diabetes, those can be fed into the model, and you can make a prediction, basically focus on, look at the probability, and based on that, you can select the patient. So you can offer things like comprehensive assessment, multidisciplinary care plan, enhanced monitoring, support services, so involving support services, advanced care plan, and you can start a lot of these, focus them on a cohort of patients most high at risk, pre-selected by the clinician. So the clinician will still look at the cases, make sure that they are actually, that they would benefit from these interventions. But the model is almost like a first filter to basically get those patients. So just a very quick look at the dashboard. So this is how the output currently looks. So at the top, you will find basically the predicted number of deaths whilst on the waiting list. And so that number can be used to essentially, you can look at different regions, you can click at different sort of demographics, so you can divide people into different demographics, and then look at specific subpopulations in order to potentially target your interventions that way. In terms of the specifics of how that's going to be used, that's to be determined. Maybe in the next HACA we can talk about how that's being used. But because it's a new tool, we still sort of waiting for those and see how it's used. But yeah, you can imagine just taking the whole population. You can isolate a cohort of high at risk. You get sort of an output like that where you see the probabilities. Then the clinician can essentially go through that and can see themselves sort of manually inspect and see, okay, so this is the patient. This is what they've got. This is the probability. Do I want to intervene with this patient? So it helps you sort of make that decision essentially. And then future developments. So that's, I think, the last slide. For future development, there's different things that we could have done. So this is a very, very simple model. The model could have been more complicated. Machine learning techniques could be used. More features could be used. Current research could be implemented, so there's more to be added. We could have used survival models as well that give you a little bit more. They're a bit more complicated, but they give you more information. So if that's sort of needed, that could be a future development. We could use mixed effects modeling as well in order to kind of give a little bit more insight and make the model a little bit more complicated, but more insightful. We should continue to obviously incorporate new clinical knowledge and research, create a QA system as well to make sure that the outputs that we're getting for new patients are reasonable, and making sure that the outputs of the models are useful and that they are actually impactful in policy making. Yeah, and that's just more information about work from my organization, from Arden and GEM. So there's another, we have two posters going, and we have a presentation by Dr. Ann and Miss Farah tomorrow at 11:30 over there. Okay, thanks everyone. No.
Thank you, Kamil. Thank you so much. And everybody's keeping to time today, which is fantastic. So I think we have a few questions coming in. So I think we're just going to pull out a few that Bianca's going to go through, and we'll see how many we can get through in the 5 minutes.
Okay, no problem.
Okay, first one, is the code publicly available for this model?
Not right now. I don't think we haven't considered doing that. No, not right now, no.
Is this model currently being used in your trust? If yes, how? If not, what's the next steps for getting it used?
In my trust? So we developed it for Cornwall and Isles of Scilly ICB. So it is currently used. So the dashboard they're currently using and accessing, and yeah, so they've been using it frequently.
How could this be used to support health inequalities?
I think if you look at the dashboard, you can probably, if you want to, you can focus on specific cohorts. So you could, for example, separate. You could, for example, get, let's say, a list of patients. Yes, so you could, for example, get a list of patients, maybe split patients based on ethnicity, look at the risk scores, let's say, and see whether, for example, patients in one group who tend to be at a higher risk, whether they're getting the same interventions, for instance, they're getting the same interventions offered, for instance. So if you match for risk, let's say, is the treatment equal if you match for risk, for instance, or match for variables? Yeah.
Did you consider outcomes other than just mortality for this or future models, e.g. lost QALYs, risk of emergency admission?
So this model is specifically designed for mortality. You could develop a different model for, what was it? For A&E? What was it for what outcome did they say? That would require developing a different model. So this one is focused on mortality. Survival models, which was another way to model this, which would be sort of a more of a regression type modeling. It's for the same purpose. It would be for the same purpose.
Did you apply any additional measures to ensure the biases in the data have been catered to when oversampling?
Mm. In terms of, I guess I'm assuming sort of, I guess, no is the answer, no. I was trying to understand what sort of bias, but yeah, no is the answer. Yes.
What feature selection methods did you use for your logistic regression model?
So just one thing to say. So even though we haven't used anything to reduce the biases in oversampling in itself is somewhat randomized. So because we used all the data that's out there, so everybody on the waiting list, including everybody who has died, we have sort of avoided a lot of biases by basically including the whole population, because that's essentially what it was. So you avoid a lot of biases by doing that. And what was the question that you just said?
You got me there.
Yeah.
They're just coming in all the time.
Which one was it?
It was this bottom one.
Okay. What feature selection methods did you use for your logistic regression model?
So logistic regression, when you use logistic regression model so basically you end up fitting a regularized logistic regression model, and then you essentially select the most predictive features, so the ones that are basically have essentially the highest odds ratios. So it's a very, very simple selection method. There's other ones to use, but this one has been found sort of iteratively and systematically to sort of perform the best on our test data, which was not used in training. So yeah, just using the most predictive features as basically said by the logistic regression model.
Did you have any issues with having a heavily imbalanced data set, i.e. one class was much more common than the other, and if so, how did you get around this?
It was the oversampling. So yeah, it would have been a massive issue. We probably wouldn't have been able to use a logistic regression model if we didn't do some kind of oversampling method. So yeah, oversampling overcame that. It's called data augmentation, so you're sort of generating data points in order to feed into the model.
Just bear with.
I don't know where it went.
It's a really good question, it just disappeared.
Yeah. You scroll down.
Okay, I'll just see if I can find it. Sorry about that. How does the model handle patients' probability of dying based on multiple factors? For example, attending clinical oncology and a rural clinic, how will they counteract each other?
So the way linear models are fitted, so we did, for example, do some multi-collinear analysis to make sure that the features that we used are independent, somewhat independent. The way linear models are fitted, as far as I understand, is they try to sort of fit because it assumes independence, it tries to independently adjust each weight whilst keeping all the other weights fixed in order to essentially establish a relationship between that particular feature. So you have a weight. You have a weight associated with each feature. So you're basically keeping the weight of a given feature, of all the features fixed, then you adjust one of the weights in order to see its impact on the actual outcome, and you do that feature by feature. So you're assuming independence, and you're assuming in the training, and in the training you actually sort of train them independently in order to establish what the weight should be, and in order to establish the statistical relationship. So you can get p-values, you can get confidence intervals by assuming. Yeah, inherently within the training, the model does that. As long as, you will struggle to do that if your features are correlated. That's why you need to make sure that your features are not strongly correlated so that you're actually able to do that. Yeah, otherwise your model would struggle. I think that's a bit of a convoluted answer, but yes.
I think this is your last question. Have clinicians been involved in sense checking the accuracy of the model? How have clinicians found the output?
So we had, yes, so they have all throughout the project. We have since checked the output. So this was actually, I think it's an ongoing process. So this has been retrospectively fitted on data from the past. So as soon as it was fitted, we already had data. I think it's an ongoing process ongoing process. So they were involved in development, and the decisions that were made in together. But yeah, it's an ongoing process, the evaluation bit. Yeah, thank you.